All right. Okay, this meeting is being recorded. All right. So why don't we wait one more minute to let the rest of the people in. I figured out this week how to get rid of the virtual waiting room, so I don't have to do that, which was nice. Good morning, Neha, Perna. Perna and I have already had many conversations this morning, just in case waking up early for this wasn't early enough. Okay, got Uzo on the line. Dr. Sen, hello, how are you? Okay, let me pull up share my screen. Okay. Oh, Lynn Nepo, I see you there. All right, can everybody hear me? Lynn,
yes.
give me a thumbs up if you can hear me. Okay, thank you. All right, we'll give it one more minute and then we'll get going. Hope everybody had a nice weekend. I did not. That's okay. Okay. Let's see here. Oh, we have quite a nice crew. Thank you for joining this week. All right, why don't we get going? Okay. So today we'll start by, as last couple of weeks I've been doing a drug a week. So today we'll start with Sotalol and remind you that this is a non-cardioselective beta blocker, which was introduced in 1970 originally as an antihypertensive agent. But later on, it was determined to also be a class 3 agent, potassium channel blockade. So it's important to remember that Sotalol is not only a beta blocker. It's not typically a mistake cardiologists make, but virtually everybody else on the planet seems to think it's a beta blocker exclusively. It clearly is not. In terms of the cardiovascular effects of Sotalol, first of all, it is in fact, of course, a beta blocker. And it's important to remember that most of the beta blocker effects of Sotalol are seen at the lowest dosage. So when you're starting Sotalol, and we'll go over what the dosage is supposed to be. At the lowest dose, you're pretty much getting about 90% of the beta blockade of the agent. And so you should keep that in mind. However, you really don't get almost any class 3 effects at the lowest doses. And so this is why Sotalol sometimes seems to be ineffective and why you end up having to, it takes a couple of days until you start seeing any impact of Sotalol, because typically in most antiarrhythmic agents, because of the potential for proarrhythmia, we always start at the lowest dose and work our way up, and using efficacy as the goal. And so you don't really see class 3 effects until you're at the moderate to high doses. And so if you have a difficult arrhythmia to treat, it's not uncommon that when you start Sotalol at a low dose, you could have the impression that it's ineffective when in fact it is. Or it might be at a higher dose. So it prolongs the action potential in the atria and the ventricles, and it prolongs the QT interval, increasing the potential for Torsades. And this is an example of the cardiac action potential, and we see that Sotalol prolongs the action potential, and that is in fact the way in which many all class 3 agents work to improve, to reduce arrhythmias. And of course, as in most things, a little bit is good, a lot is bad. And so a little bit of prolongation in the QT interval occurs with this, which is actually antiarrhythmic, but can be proarrhythmic in the wrong patient. Pharmacology is that it is well absorbed from the GI tract, more than 90%. And the peak serum concentrations are achieved 2 to 3 hours after administration. The half-life is about 7 to 8 hours, and it is shorter in children. And the drug isn't metabolized, it's just excreted by the kidneys, which is important to remember because you want to reduce your dose when somebody has renal insufficiency. And this is the dosing range. In children, we dose by meter squared, and the dose is about 80 to 180 milligrams per meter squared per day. Typically, we divide at Q8. This Q8 dosing is special for children because of the short half-life in children. A study that was done probably about 20 years ago now by Phil Saul, which was a pharmacokinetics and pharmacodynamics study, demonstrated that children do metabolize the agent quicker, which is how we came to Q8. And usually we would do Q8 up to about 10 to 12 years of age. At that point, metabolism starts to look more like adults. In adults, the starting dose is 80 milligrams BID. It comes as an 80 milligram tablet, and you can increase it to 160 milligrams per day. And I would just remind everybody that there is now an IV form of Sotalol, which I have not reviewed today. It is still an agent that's sort of looking for a disease. There are a handful of papers that have come out in the last 1 to 2 years demonstrating that it might be effective at pretty much any arrhythmia. But I think there is no trial of this agent to my knowledge yet. And it's still, I think, some people love it. I think people use it for junctional ectopic tachycardia sometimes. 80 BID is the same as 160 per day, Raymond Morales is asking me. Yes, it is, but again, it's 80 BID. And I'm sorry, you're right. This is a mistake. I meant 80 milligrams BID. That's an error on my slide. Thank you, Dr. Morales. So yeah, so you can increase to 80 to 160 BID. So typically in an adult-sized patient, you'd start at 80 BID. If you see inadequate effect, typically I'd go to 120 BID. It comes as a 120 tablet, and then if that fails, then the max I would go would be 160 in most patients. When you start somebody on Sotalol, you need to measure the QT interval every day for the first few days. This is an agent that traditionally in pediatrics we start in the hospital because of the risk of proarrhythmia. Although in general, Sotalol is not a very proarrhythmic agent. Obviously, if someone has a baseline prolonged QT interval, we would be more concerned about starting this particular drug. Okay. And so again, in terms of how we use it, think about its use in pediatrics. Generally speaking, this agent is most commonly in pediatrics used for forms of supraventricular tachycardia. It can be used for atrial arrhythmias. Just at this moment, we are using it in a postoperative patient who has very bad ectopic atrial tachycardia with some effect. And then it can also be used for ventricular arrhythmias. But usually in children, ventricular arrhythmias are serious enough that we don't trust Sotalol alone, but there are patients in whom it is effective and in which it's used. So again, generally speaking, patients, when they're started on Sotalol, we do that in the hospital. It is possible that over time there may become increasing comfort with not starting it in the hospital. If any of you actually listened to my podcast, you may recall that we reviewed a paper a few weeks ago from Boston Children's on the concept of starting Sotalol as an outpatient. And they, although they don't do that as a routine in Boston at all, they did identify a group of patients in whom they felt that the risk of serious problems or problems with starting Sotalol as an outpatient were low. And so I would direct you to the paper, which came out just a couple of months ago. Okay, so at this point, let's move on to some interesting tracings, or maybe not that interesting. This is a patient that came into the emergency department recently, is an 8-year-old who had core triatriatum repair and felt palpitations. I think I'm going to ask Dr. Let's see here. I think I saw Dr. Namrita Mozumdar on the line.
Hi, Dr. Chas.
Hello, Namrita. Welcome. Good morning.
Good morning.
So what do you think this patient has?
This is the heart rate's like a little above 150.
Yes. It's a little slower than
Yeah, a
150.
little, so like 100. Mm,
It's about 120, I believe, was the actual heart rate. Got to get that part right, Nemrita.
yeah.
Very okay.
Looks like flutter, atrial flutter.
And where are you making that diagnosis, and how are you making that diagnosis?
So if you look in like lead 3,
Uh-huh.
see two, two P waves and then QRS. So it looks
Right. I agree.
2 to 1.
This is atrial flutter with 2 to 1. I would direct you to lead V1. I think it's the
Oh,
most
yeah.
clear in V1 and in V2. And I think about a week or two ago, I mentioned to everybody that years ago with Leo Lieberman and Tom Stark at Columbia, we did this very cute study in which we took about 100 patients who we had ablated. We knew the mechanism of SVT. We cut the EKGs up into 12 little squares, and we had each of us decide what the mechanism of tachycardia was, and then compared it to what we knew was in fact the truth. And what we found was that lead V1 was in fact the best lead to determine a tachycardia rhythm. So, and the second best was lead 3. So it's interesting that you went to lead 3, which I do agree. You can see the P waves here. But we found that if you had lead 3 and V1, you got the diagnosis like, I think we got it 96% of the time or something along those lines. So it's just an interesting observation that those two are good. And I just mention it because in almost every ICU on the planet Earth, lead 2 is displayed, but actually lead 2 is terrible. And we only got it like 79% of the time. So anyways, okay, so now Namrita, you have this patient in the emergency department. What are you going to do about this patient? They're hemodynamically stable. They feel palpitations. What's your next move, or what do you want to know about this patient?
I want to make sure she doesn't have like a thrombus or how long she's been in atrial flutter.
Okay, so she tells you that she felt it about 12 hours ago. When she woke up, she thought she felt her heart beating fast. It's now, let's say it's 8 p.m. You're in the, of course, it always has to happen at 8 p.m. in the emergency room.
Right.
Or 4:30 in the morning. Those are our two favorite times. What are you going to do now? So it's 8 o'clock in the evening, and patient tells you that 12 hours ago, roughly 8 in the morning, when they woke up, they felt this.
Well, you have to do an echo. TE is the best way
Why are you doing an echo? What are you looking for on the echo?
to rule out an atrial thrombus or any sort of
Okay.
thrombus that would affect direct cardioversion.
And what else are you looking for on the echocardiogram? I agree with you 100%. The thrombus is a serious issue.
And function.
Function, right? If you've been in tachycardia for a long time, you can have a tachycardia-induced cardiomyopathy. If you take a normal patient, a healthy patient, you leave them at 120 beats per minute for a long time, in a few days, I'm sure the function will become depressed. You'll develop a tachycardia-induced cardiomyopathy. So you do a transthoracic echo, you do not see anything. Are you comforted by the fact that, what do you want to do now? So now you have a 12-hour history of tachycardia. You've done an echo. The function is normal. You do not see an obvious thrombus. What do you want to do?
And I would admit her overnight and start rate control medication and then see if she's still in flutter in the morning and she would need cardioversion.
Okay. Well, let's take a step back. You're worried about, what are you most worried about in this arrhythmia? You've already mentioned it.
Well, it can cause thrombus.
Right, thrombus. So if you've admitted the patient to the hospital, do you want to do anything to mitigate the risk of thrombus?
Oh yeah, start like Lovenox. Not
Yeah.
Lovenox, aspirin, but I guess if she's...
Yeah, normally we would not trust aspirin to prevent thrombus. So you would either start Lovenox or you could start just unfractionated IV heparin, maintaining a therapeutic PTT. Because once you do that, the clock has stopped in terms of thrombus formation, right?
Right.
Okay, so you put the patient on heparin and you want to rate control. How successful do you think, well, what would you consider using for rate control in a patient like this?
You could use diltiazem or beta blocker.
Right, you could use diltiazem or a beta blocker. The dose of diltiazem is typically 1/4 milligram per kilo, given over about 5 minutes, and then start a dose of between 0.05 and 0.15 milligrams per kilogram per hour.
Mm-hmm.
Or you could put the patient on esmolol. But I'll tell you that it is usually very hard in a young patient who's 8, who has a good AV node, with this type of rhythm. It would be difficult to AV block this patient. You would need very high doses probably, because the AV node is very good in a young patient. So in this age range, at this heart rate, we elected to not do any AV node blocking. Okay, so now it's the morning. The patient's been receiving their heparin. They are still in tachycardia. What do you want to do?
I would do cardioversion, DC cardioversion.
Do a DC cardioversion. Do you need to do a transesophageal echo, or do you not?
I would do it just to make sure that there's no intra-atrial thrombus.
That's right. So normally we would normally do one. Now the reason we would do one is, now if you had the problem is that people who have atrial flutter or any kind of atrial arrhythmia, oftentimes they will tell you that they know exactly when the tachycardia began. And I'm sure they're not lying to us. But the problem is that oftentimes people mistake rapid conduction of the tachycardia for the beginning of tachycardia. So you don't actually know. If the patient says, well, at 8 in the morning yesterday, I felt tachycardia. What you don't know is, were they in this rhythm all along and they started climbing stairs and they started going 1-to-1, and that is what they're considering to be the beginning of tachycardia. So sometimes it's challenging. If you don't really know for sure, we would normally do a TE, although I will tell you that the risk of thrombus in atrial flutter is substantially lower than the risk of thrombus in AFib, or alternatively in a congenital patient like a Fontan who has slow, sluggish flow. So the bottom line is, normally we would do a TE. In this particular patient, this was unfortunately not her first episode of flutter. She's a very good historian. She'd had multiple episodes of flutter in the past. She was even status post an unsuccessful attempt at ablation in the past. And so we elected, based on the fact that the echocardiogram was normal, meaning normal function and no evidence for an obvious thrombus, although recognizing, of course, that a transthoracic echo is a poor way to tell that, we elected to cardiovert. So how much energy do you want to cardiovert, and how would you do that, Amrita?
You have to synchronize. So you use
synchronizing to the A or the V?
The V.
Right, we're doing ventricular synchronization. Why are we doing that? Of course, because we don't want to put a shock on a T wave and induce something bad. Okay, so I think that the bottom line is so how much energy do you want to give? The patient weighs, this is a somewhat obese child. I believe she weighed 45 kilos.
So you could do 0.5 to 1 joules per kilogram.
That's right. That's right. And in fact, the choice on our device was, I think, either 20, 30, or 40. And Dr. Bonsall chose 30 joules synchronized, which resulted in sinus rhythm. Okay. All right. Very good. Basics, but important. Okay. Let's call Dr. Neha Lawalia. I believe you are on the line. Is that right?
I'm here.
Hello, thank you.
Hello.
So this is a patient having an electrophysiology study in 2003. And that's how old this tracing is for me. The patient is being paced in the atrium and something happens, and I'd like you to tell me what you think it is. And whoever made this tracing, which I will take responsibility for, was kind enough to measure 2 things for you.
So in the beginning, you see you're pacing in the atrium, and then you see the Hes and CS with RV, so it's like a normal conduction that you would expect. And then at the third beat,
I will tell you the entire tracing is apacing, just
right,
so that it's not confusing.
sure. You see that there is a jump in, like you see in the CS after the fourth beat, you don't see the HV becomes really prolonged.
Is it the HV that became prolonged? What am I measuring here?
In the beginning?
Well, I'm measuring an interval here and an interval here, and I'm measuring the same.
The AH interval is
the AH interval, that's
interval
not the HV
is
interval.
prolonged. Yeah, 105 to 200. Sorry,
Right.
yeah.
Right.
So there's a jump from 105 to 200 in the AH interval. So it's like dual AV node.
Right. This is an example of a jump from the fast pathway to the slow pathway with rapid atrial pacing. You see that we're at the beginning of the tracing, we're pacing at cycle length 400, which is a rate of 150 beats per minute. And when we drop the cycle length by 10 milliseconds, we see that the AH interval, which was 105 milliseconds, goes out to 200 milliseconds. And you see that all of the rest of the beats have this long PR or AH interval. And that is suggestive of the presence of dual AV node physiology. Does not, of course, mean that the patient has AVNRT, because a real percentage of healthy patients who do not have SVT do have dual AV node physiology. But if one were doing an EP study, this would be, shall we say, a piece of evidence in favor of the possibility that the cause of SVT in this child was AV nodal reentrant tachycardia. So this is a very typical kind of tracing that one might see on their American boards in cardiology. And so I always emphasize that the first thing you always want to look at is the top of the screen. Universally, in every laboratory I've ever worked in or seen, the top 3 to 5 leads are going to be EKG leads. And then it's always worth looking at the legend on the left side of the screen, because how this is displayed on the screen varies from center to center and doctor to doctor. Even in our own lab, Dr. Love and I will represent where, in terms of the order of these, they're different. So in this case, HRA, high right atrial catheter in the right atrial appendage, followed by, in this case, 3 CS pairs, distal, mid, and proximal. And then in this laboratory, we would display the coronary sinus from proximal to distal. So this is somewhat non-intuitive, because the Hes channel is being displayed from distal to proximal, but the CS channel is being displayed from proximal to distal. So this is, an idiosyncrasy of the person who's running the lab. In this case, it was me. And here's the right ventricular apical catheter, and then on the bottom there's a stim channel, which is telling you what you're doing. So whenever you're looking at a tracing, first thing you want to do is remind yourself what channel is what. In labs that I have worked in, typically we make the Hes yellow and the CS green. I've often fond of saying that we are victims of our training. So at Boston Children's Hospital, Dr. Walsh, Dr. Triedman, Dr. Saul, all the various characters there, Dr. Alexander, always displayed it in these colors. So I always did. And then, of course, I trained Dr. Lieberman, so he does it that way at Columbia. Lots of people, for some reason, choose these colors, but you can't rely on that. In different labs, some labs don't even like colors. But the point is, you want to look at the legend so that you know which lead is which as you're looking at a tracing. So this is an example. And if you got faster and faster, meaning that the cycle length would drop lower and lower, and you continued to have a long AH interval, that would be consistent with so-called sustained slow pathway conduction, which is a sign of dual AV nodal physiology. All right, nice job, Neha. Okay, I believe I saw Dr. Tsen on the line. Are you there, Dr. Tsen? Diana Tsen? Let's see here. Somebody's in the chat room. I am, but she does not have a microphone. Okay, very good answer. I like that. That's a good way to get out of answering a question. So therefore, I see my good pal Uzo here. Uzo, how are you?
I'm well, Dr. Paz. Good morning.
Good morning. So this is a tracing from a very old textbook that an old friend of mine, Ehud Krongrad, gave me on the day he left the hospital and retired. He said, if you want any of these books, be my guest. So I took this book, and so this is a very old tracing. And basically, I'd like to ask you, there is heart block demonstrated on this tracing. I'd like you to share with me what type of heart block you believe this is. Where is the block, I guess, is the question.
So looking at the Relead, the A rate seems to be consistent. Just looking at it roughly.
It's hard for you to tell. It's hard to tell exactly what that rate is, but let's assume for the sake of discussion, it's a rate of about 60, okay?
Okay. But what I mean is the A's seem to be appearing at regular intervals. Again, it's hard to say because I can't see the scale of the paper scale, but it seems to be.
Well, actually, the paper scale is right here, but I would agree with you that I took this photograph in a somewhat cockeyed manner, and the left side of the screen is bent compared to the right. But let's say, for the sake of discussion here, that the A to A interval is constant in this tracing.
Okay.
Say a rate of 60 or 70.
Okay, and then looking at the Hes catheter, the Hes tracing, you can see initially you have an A to H with no V, with no conduction, and then intermittently you have a V. So for the second and third beats, you have conduction to the V, and then for the next two beats, there's no conduction through those. And then you have, so intermittently you drop your V.
I agree with that. All those.
So this would be.
So what level of block is this?
The
choice is either in the AV node or in the Hes Purkinje system.
So I would say it's in the AV node.
Well, you had a 50% chance. Sadly, you got it wrong. It was a good effort. You had it right all along, right up to the very end, Uzo. Okay. So I would remind you that we cannot actually record. One of the great ironies of electrophysiology studies is that we cannot record an impulse from the AV node.
That's true.
We can record the atrium and we can record the Hes and the ventricle, but we cannot actually record signals from the AV node. Now, some have suggested that if you were in a completely electrically isolated room with beautiful recording equipment, you might be able to record AV nodal conduction, but generally speaking, you cannot record AV node on in an electrophysiology study. So we infer where the AV node is based on the time it takes to go from the low right atrium to the Hes, which is measured as the A to H interval. And you'll recall that a normal AH interval is between about 50 and 120 milliseconds in most normal patients. And they were nice enough to tell us that the AH interval was 50 in this patient. So as long as there's an H that follows every A, we know that the AV node is working okay. But when you see no V after the H, this is what we would refer to as InfraHessian block. And this is a worrisome form of block. And in fact, I think you could argue that this HV interval is a little shorter, maybe even than this HV interval. So it's almost as if there's some kind of wanky buck going on in the Hes Purkinje system here. And so this is InfraHessian block, and this is the type of block that we surmise or imagine is most common in patients who've had postoperative heart block. And InfraHessian block is a higher degree of heart block than AV nodal injury, and virtually always is a pretty straightforward indication for a pacemaker in most patients. So, all right, good effort there, Uzo. All right. Let me see here who we got. I think I see Sanjeev Gupta back from his COVID detail. Dr. Gupta, are you there?
Yep, I am. Good morning.
Welcome back, Sanjeev.
Thank you.
All right, so this is a 12-year-old with mild dizziness and palpitations who's in a stretcher in the emergency department. You've been called to see this patient. What do you think is going on, and what do you want to do?
So it looks like it's a wide, complex. I'm going to start off by saying it looks ventricular, even though I'll talk about why I think maybe it couldn't be, but it looks like a wide, complex, polymorphic, irregularly irregular tachycardia.
I would agree with all those statements, yes.
So I'm trying to look for clues as to what this might be. So the one thing that jumps out right away, since it's wide, complex, and irregularly irregular, I want to make sure that it could be an SVT with aberrancy or an accessory pathway, and it could be like AFib, like going down an accessory pathway, and that's why it's wide, complex.
Mm-hmm.
So that would be maybe my first thought.
That would be the best thought, because that is in fact what this is, right? This is pre-excited atrial fibrillation with rapid conduction down an accessory pathway. And, we would, so does it surprise you that the patient is conscious and talking to you in the emergency room?
No, it would surprise me more, I guess, if this were an actual VTAC.
Right. So this could easily degenerate into VT or VF. And in fact, this is why patients die from WPW, right? Is that they get rapidly conducted pre-excited atrial fibrillation. And I've reviewed this previously as recently as 2 weeks ago, but this is such an important thing to get right in an emergency that I tend to emphasize this type of tracing quite frequently, because you never want to miss this diagnosis, because it could be a lethal error. So this is rapidly conducted AFib. And again, the reason people die from WPW is that this degenerates into VF, and then patients die suddenly. And there's actually a beautiful case report by Melissa Olin, who is a nurse practitioner at Miami Children's, that was published in Circulation a few years ago, in which they actually have an event recorder from a patient who had WPW who died, and recorded a degeneration of orthodromic reentrant tachycardia turning into atrial fibrillation, which was rapidly conducted and became VF, and tragically that child died. So this is the reason that we worry about sudden death, not SVT, although some believe that that SVT usually precedes this rhythm. That is unclear if that's true, but some people believe that. All right, so you're in the emergency room. What do you want to do for this, Sanjeev?
You could cardiovert, or you could use Procainamide.
That's right. Those would be the two most common first lines. So you could give IV Procainamide, and typically we would give 5 per kilo, followed by another 5 per kilo, depending on the result or the effect. But usually it takes about 10 to 15 milligrams per kilo to get the full effect of Procainamide. And Proc might terminate the atrial fibrillation, but at the very least, it should slow accessory pathway conduction, right? And so make this less likely to be a life-threatening arrhythmia. Let's say you don't have any Procainamide in the hospital. Anything else you could give for this?
You could give, I guess you could give a beta blocker. I'm not sure if that would be the best.
No, that would actually be, depending on who you are, some would consider that to be contraindicated, because it could potentially block the AV node and enhance accessory pathway conduction. So in the adult world, they actually think beta blockers are dangerous for patients with WPW
Flecainide?
rhythms. You could give a dose of oral flecainide. That's possible. That might work. But again, that's going to take a few hours to be effective and may or may not work right away, or at least a couple of minutes. You could give IV amiodarone potentially. Might even be able to give IV Sotalol, although I've not heard of anyone doing that for this. Now, let's say you're going to cardiovert this patient. How many joules per kilo would you give this individual?
1 joule per kilo.
Yeah, I think a half a joule to 1 joule per kilo would usually be the correct dose to treat this, this arrhythmia, because this is actually atrial fibrillation. All right, so you've cardioverted the patient. They have WPW. What do you want to do now for this patient? Can this patient go home? What's the next step in your view?
So I would suggest that this person get an ablation. They're 12 years old. They're presumably a good enough size, and this has proven to be a risky pathway.
That's right. And what about this tracing tells you that this is a risky pathway?
That it's conducting at a rate of about 300, so it's definitely in the high risk category.
That's correct. So I remind everybody, and for the fellows at Sinai, you guys know I've shared with you this paper more than once already in the year plus that I've been here. George Klein in 1979 in the New England Journal of Medicine published a landmark paper in which he demonstrated that if there was conduction through an accessory pathway at rates exceeding 250 beats per minute, that the likelihood of sudden cardiac death was substantially high. And so they did that by doing EP studies in a bunch of people who had exactly this rhythm, and then testing the pathways. And so the bottom line is, if you can conduct through your accessory pathway at rates that exceed 250, we would consider that. I think anybody would consider this an EKG of somebody who is at high risk, therefore somebody who should be cardioverted. I'm sorry, should have an ablation at some point. If they can't have an ablation for whatever reason, they should at least be put on some type of a pathway blocking agent. In the old days, Procainamide would be used. You could use flecainide potentially, or even Sotalol on a temporary basis. But really, the correct answer in this case is that the patient should have an ablation. Yeah. Oh, and what do you think about giving intravenous digoxin to this patient to slow the rate? Good idea. Bad idea.
Good way to get sued.
Say that again. I'm sorry.
It sounds like a good way to get sued.
That's right. It's a good way to get sued because digoxin could potentially turn this into VF and enhances pathway conduction. Very dangerous. Similarly, you would never give a calcium channel blocker to a patient like this. Okay, very good. All right, I wanted to go over this download. This is a different patient, but a similar concept to what we did last week. A couple of people commented on it, and I thought I would just go over this one more time, this concept of how fast can a pacemaker track atrial rhythm. So this is a remote download from a patient who, this is a download, 25-year-old with complete heart block. And we'll look at this is a Boston Scientific device, but of course pacemakers all work very similarly. And this is not the same patient we reviewed last week, but it's a similar concept. So this is the patient's setting. The patient is programmed DDD with a lower rate limit of 45, maximum tracking rate of 170. And this device can alter or vary the paced AV delay and sensed AV delay through a range. This particular doctor did not want a range of change, so set them both at 150. And the postventricular atrial refractory period is also set at 170. So this is the patient's baseline. And when you, a lot of pacemakers have event recording as part of their tracing. And we see here that the patient is in asensed V-paced rhythm, which is what we would anticipate a pacemaker would do in somebody who has a complete heart block. But what we see here is that at this beat, we have an asensed event, but we don't have a V-paced event. And then there's another A, which is paced, and then again, are A-sense V pace with this notation MT. So the question, of course, is why is this tracing irregular? So this is basically an example of an anti-tach pacemaker-mediated tachycardia mechanism. So remember that that pacemakers, some people who have complete heart block have antegrade complete heart block, but do continue to have retrograde conduction. Most people who have heart block also have heart block both antegrade and retrograde, but rarely patients can have retrograde conduction in the setting of antegrade block. And pacemakers, if you were to pace the ventricle and go retrograde through your AV node back to the atrium, the pacemaker could potentially sense it and then pace the ventricle to it, and it would become essentially a loop where you're going, pacing the ventricle up the AV node, pacemaker senses it, paces the ventricle, and so on and so forth. And so as a means of preventing that, in this device, they have, this is the description of the anti-tachycardia algorithm in a Boston Scientific device. And what they do is, after 16 consecutive ventricular paced events and atrial sense cycles, if it happens at the programmed maximal tracking rate, it will start the anti-pacemaker mediated tachycardia algorithm. Also, the variance between the ventriculo-atrial interval should not exceed 32 milliseconds, which is again a way of making sure that the VA, if the AV node is conducting retrograde, then the VA interval should be fixed or fairly stable, so they're giving you up to 32 milliseconds. So in this patient, first of all, what is the maximum atrial tracking rate? And so the way that we can determine what the maximal tracking rate of any pacemaker is to calculate the TARP, or the total atrial refractory period. And the TARP is equal to the AV delay plus the postventricular atrial refractory period, or the PVARP. In this patient, you'll recall that the AV delay was programmed at 150 milliseconds and the PVARP at 170 milliseconds. And so if you add those two together, you get a cycle length of 320 or a rate of 187.5. In other words, at the present settings as made in this pacemaker, as programmed in this pacemaker, this device could track an atrial rate up to 187.5 beats per minute. But in this tracing, the TARP is 320, so we can go to 187, but we see here that at a cycle length of 353, we are getting the anti-tachycardia pacing occurring, or the intervention occurs. So why is that? Well, it's quite simple, actually. It's because the maximal tracking rate programmed by the person who programmed this device was 170. And if we divide 353 into 60,000, that's 170. And so the reason that this patient, I'll go back here, the reason that this patient is not tracking above 350, cycle length 353, is because the person who programmed the device set as the maximum tracking rate 170, even though this program would have potentially allowed tracking up to 187.5. And so what does that mean? How would we reprogram the device to allow it to track beyond 353? The answer is to just increase the maximal tracking rate to 187.5, which is equal to the total atrial refractory period. Actually, that's beats per minute, I'm sorry. So I just thought that would be an interesting tracing to review. It's an important concept, so. Okay. Grace Kong, I believe I saw you on the line.
Hi, Dr. Pass.
Good morning.
Good morning.
So this is an example of ventricular tachycardia. I stole this from the famed Tehran Arrhythmia Center. What's going on in the atrium here, Grace?
Well, looking at the tracing, there are more V's than A's, and it looks like initially it's a V that retrograde conducts to the A,
Mm-hmm.
And so, but the interval changes, and after the fourth V, there's no retrograde A conduction.
That is correct. Good observation. So can you comment on what's happening to the ventricular-atrial interval?
It's prolonging.
So what do we call that?
Decremental, it seems. So we think that it might be going through the AV node.
Right, and so this would be consistent with so-called ventricular-atrial Wenckebach, right? So the VA interval is getting longer and then longer. Well, actually, I should say, so here's the regular VA, gets longer, longer, and then it blocks. And then the sequence begins again, okay? So just as you can have antegrade AV Wenckebach through the AV node, so too can you have retrograde VA block. So this is retrograde Wenckebach through the AV node in the setting of ventricular tachycardia. And I'll just remind everybody, you know, we talked a moment ago about how to look at electrophysiological tracings. In this case, as I mentioned earlier, almost always it's uniform to put some EKG leads at the top, and this particular laboratory puts lead 1, 2, and V1 on their screen. Then they have 2 pairs for the right atrium. Notice that these are in blue, and the other tracing they were in red, so you can't read anything into colors of any sort. Then they have their Hes, and their Hes is displayed actually the reverse of the way it was in the other tracing, with the proximal first and the distal second. And then they have a right ventricular distal, and no coronary sinus is displayed on this tracing. So there was no CS catheter presumably in the patient. And notice that the stim channel is showing no stimulation. This is spontaneous VT. Okay. All right. Any questions on that one? Okay. All right. Let me see here. This is a 16-year-old who has a TET absent valve. And this patient came to the lab because they were having some pauses on their electrocardiogram, on their Holter, I should say. Is Perna Bonsall on the call here? I think we spoke earlier. Perna is on service, so she may not have been there. So I think I see Simone hidden as Sim J. Are you there, Simone Javeri?
Yes, I'm here.
Hello, Simone. Okay, so what do you think we're looking at here?
Okay, so I see some, so looking at the atrial leads, I see some intermittent atrial activity. I also see a Hes signal, but I'm trying to look for ventricular signals, and in the RV catheter, I don't see any electrocardiogram.
Let me just say that this is a somewhat unfair question, and I apologize. You just identified something that I didn't notice when I put this in. This channel was not plugged in, so there's a good observation. It's an unfair question, so forget that you see this channel.
Okay, so if I look at the the Hes distal, I think I see an A, H, and V in the third beat. So let me just start from the beginning. So the first beat, I only see a V, so I'm probably missing the prior part. The second beat, I see an A and an H, but there's no HV conduction. There's no V, and there's no ventricular escape either. And then there's AHV, and then there's an AH with no V. So looks like there's an what is the cycle length, Dr. Pass, of the?
Well, it looks to me like the cycle length is about 800 in the atrium, roughly.
800 in the atrium.
So that's a rate in the about 70, I would say, similar, close to 70.
So, so that's a fair atrial rate for a 16-year-old, but I guess there's so there's high degree AV block, potentially InfraHessian.
Yes. So this is an example of InfraHessian Block. This is, in fact, exactly the same type of tracing that Uzo went on just about 20 minutes ago. So so we have conduction through the AV node with a long looking AH interval, and then H with no V, AH, no V, AH, no V. So this is an example of InfraHessian block. There are rare patients who develop heart block late after surgery. So this patient, what would you do with this patient if you had done this EP study? What would you recommend?
I'd recommend a dual chamber pacemaker.
Yeah, this patient really would benefit from a pacemaker. Why do we pace patients like this? In other words, this patient is not feeling unwell. This was identified on a Holter. This observation of intermittent block. Why do we care, and why do we? I agree with you 100%. This patient is indicated. A pacemaker is indicated in this patient, but why? Why do they get a pacemaker?
Because if he's asymptomatic, they're potentially at risk for progression to complete heart block and sudden death.
Right. So there are studies that have been done many, many years ago, which have shown that if you have high-grade AV block following congenital heart surgery, you are at risk for sudden cardiac death. That is the reason that we put pacemakers in people who have had open heart surgery, but might have an adequate escape rhythm. Now, in this patient, this is not an adequate escape rhythm, right? This is a ventricular rate. This R to R interval, we can see these are at 1,000 milliseconds. So this is a heart rate of like 50 or 40. So this is a very slow heart rate. But the point is, this is what we would call high-grade second-degree AV block because it's InfraHessian, and the indication would be pretty strong for a pacemaker in this setting. Let's see what so very good, Simone, thank you. And this will be our last question of the day. I'm going to call upon Dr. Rochelson. He's here, I know. Where is the accessory pathway in this patient with WPW? Again, I will credit Dr. Ehud Krongrad for this ancient-looking tracing. And let me just tell you what these say. These are the 4 ECG leads. We have a high right atrium. There's a single Hes channel or Hes bundle electrogram. This is the proximal CS, the distal CS, and right ventricle. Ellis, are you still on the line?
Yeah, can you hear me?
Yes, we can. Thank you.
So the patient's in sinus rhythm. They're pre-excited. And I think the earliest and the shortest HV interval and the earliest ventricular electrogram is in the distal CS pair. Right. So I think this is likely a left-sided accessory pathway. Exactly,
that's correct. So this is a very simple demonstration of the fact that the A to V time here, this is the atrial electrogram and this is the ventricular electrogram. The AV time is very tight here. This ventricular electrogram, notice if you compare it in timing to the V, normally when there's not an accessory pathway, the earliest ventricular electrogram should be in the Hes because that is how we conduct from atrium to ventricle. But when a patient has an accessory pathway, if there is an electrode near to that area of the pathway, you will see ventricular depolarization earlier than you would through the AV node. In this case, the earliest ventricular depolarization on the intracardiac catheters is located in the distal coronary sinus. So this would suggest that this is a left-sided accessory pathway, meaning that the pathway needs to be ablated in the left atrium. So this type of question is guaranteed to be on your board examination, identification of the location of a pathway. In my boards, I remember 22 years ago that the question put a catheter in the right atrium on the lateral right atrial, lateral right AV groove, and there was a signal that looked like this, and you had to answer that it was the right-sided pathway. In this case, this would be a left-sided pathway. This is a little easier because they've only given you 2 coronary sinus pairs. Most laboratories display 4 or 5 coronary sinus pairs, but I think it's quite obvious that the AV interval in the distal coronary sinus pair is much tighter here than it is in the proximal, which is near the mouth of the coronary sinus, which isn't terribly far from the Hes. So these Vs are much later than this V, so it's a left-sided pathway. And I think with that, we're going to call it a day on EP conference. Thank you very much for joining. We'll be back next week on, I guess, well, the first week of May, Monday morning, 7 a.m. Eastern Standard Time. I've been recording this conference, and I will put up a copy of this meeting online through a Dropbox link if people are interested in sharing it for some reason. So thank you very much, and everybody have a good day. Be safe. Bye-bye now.
Thank you.
Bye.
Thank you.
Thank you.